Hey, everybody, this is Erica Mello, and welcome to episode number 99 of Tough to Treat. And Susan and I want to thank everybody who's left us a testimonial. And if you listen to the podcast, you know we are on a mission to get 100 testimonials by episode 100. And since we release every 2 weeks, we need one more. We are at 99 testimonials on Apple Podcasts. And thank you so much wherever you've left us a review. We truly, truly appreciate it. We would like to get one more by episode 100, and that is within 2 weeks. We are going to put everybody's name in a drawing who's left us a review over the past 4 months, because we really, we're on a mission to get this, and it's important, and it's meaningful for us to get to that 100. So if you haven't left us a review, please, if you found this podcast valuable, please consider leaving one. Thank you. This episode is a re-release of one of our most popular episodes to date, actually the most downloaded episode, and it's on shoulder pain. And I'm going to give you a little bit of a case study history beforehand. So before the actual podcast. So this is, it's called, Is Shoulder Pain Really Shoulder Pain? If you've listened to us often enough, the shoulder could be the pain generator. We have to find out what the pain generator is, right? But is it the driver, right? Is it the driving area, the driving reach of the body? And so this episode really dives deep into that. But I want to talk in an intro about 3 patients of mine, because I think this will set up the podcast quite nicely. And Susan and I will do a podcast at some point on each one of these individuals. So these 3 patients are all present with the same symptom, anterior shoulder pain. And I think if you go back to your caseload, as we tend to do chart reviews, and I think that's the best way that we learn as clinicians, and you see what right and what went wrong, and would you have done something differently. And I think with these 3 patients, they're all similar in the sense that they have the same symptom, but all really different in their meaningful movements in terms of what bothers them and what their drivers were, and certainly how you would progress exercise. And once again, this is, Susan and I will dive deep into each one of these in a separate podcast. And I think that I'm going to just do a brief description, but I'll give you some key clinical pearls that I think you all should look at when you treat shoulders or when you evaluate shoulder pain. So the first patient is a gentleman in his 40s. He had longstanding shoulder issues, right anterior shoulder pain, saw a group practice here in New York City. They gave him sort of your cookie cutter internal external rotation, cuff work, and then some shoulder like seated rows, which made him worse actually. The rows more so than the cuff work. And he continued with them for a little bit and then decided he was going to move on. So his main issue was, I can't lift my arm above my head at end range. So this guy is super hypermobile. So in order for him to feel heard and listened to, I needed to assess end range shoulder flexion. And sometimes that can be difficult as a new clinician, but as your skills get better, you will be able to assess some of these more difficult positions, so to speak. And at end range shoulder flexion, a lot of, osteokinematically, it's a bit different than just with initiation, right? Most non-optimal movement patterns in my clinical experience start with literally initiation, like from the get-go. It's like the timing. The minute you lift the arm up, something's happening that shouldn't be happening, or they're symptomatic, right? So with him, I needed to go to end range. And so I assessed what I call a single arm lift. And I call it a SAL. So at end range. So I assessed that with him. He has a history of a wrist fracture on the same side of his shoulder pain, super hypermobile, so multiple back, general aches and pains and injuries, multiple over the years, because he was also a professional soccer player. So with him, the meaningful movement and the meaningful experience was assessing his SAL at end range. Okay, I will leave you with that for now. I will return to him in a second. The second patient is an older gentleman who, in his 70s, prior wrestler and a former, when he was younger, in a former life, I like to say. And he, big bulked up, same symptom, anterior shoulder pain on his left side. And he just literally couldn't cross his body. So he couldn't take his left arm to touch his right shoulder. That was it. He could lift his arm above his head. He could put his hand behind his back. That was it. That was like, Eric, I can't put my arm on my right shoulder. So with him, different movement pattern. I feel confident in my clinical skills that I could assess that cross body. But if you don't have that skill set just yet, you could easily assess a SAL on that same side. Okay. So you will glean very similar findings. I'm just going to leave it at that. Okay. And then the third patient is a woman in her 50s, left anterior shoulder pain as well. She had a problem lifting her arm above her head and putting her hand behind her back. Typical classical shoulder symptoms, right? No prior injuries, no prior medical issues at all. So back with my first patient, the guy who was super hypermobile, I will tell you in brief what I looked at and what I found, and then I'll tell you why. And I'm going to do that with the next two patients, and then you'll dive into our podcast. So this is like the pre-podcast. So with him, because he had a right shoulder pain, I assessed his SAL. When I assessed his SAL, he had his typical sort of right, humeral head, medial compression, a bit of, we call it, like Shirley Starman likes to call it, an anterior glide. Common, very common. But what I felt with him is I felt like, especially at the initiation, a lot of medial compression. You see a lot of the muscles that tend to do that in the shoulder tend to be, subscapularis is a big one. Pecs tend to be a super medial compressor as well. But right at the end range, which was really, for him, what was most meaningful, he had a thoracic, like we call them rings. LJ Lee, a physiotherapist up in Vancouver, has done a lot of work on the thoracic ring approach. And I've done a lot of courses with her. So when he lifted his right arm up, his, ribs 3, 4, 5, and 6, he had this right translation. We call them rings, right? He had this right thoracic translation, and he was symptomatic when that happens. The timing of his symptoms and the timing of his thoracic shift were pretty much on par. So the way I assessed him, I determined that because of the way his shoulder was positioned just in sitting, and when he initiated his SAL, he had a lot of medial compression and this anterior glide, once again common, but giving him seated rows would have reinforced that non-optimal pattern, right? So when someone does shoulder extension or seated rows, what do? They jam their elbows back, they retract their scapula, and their humeral head shoves forward, right? Impinges the long head of the bicep, which is exactly what it did with him. That was one of the main muscle vectors I had to release on him. So just think about, what's the impairment? And with him, it was medial compression mostly of his shoulder and a little bit of an anterior glide, but he had this thoracic translation. So just treating this guy's shoulder would not have gotten him 100% better, wouldn't have gotten him 80% better. You need to treat his shifts, his thoracic shifts. And, that's a topic for another podcast, how I assessed and treated that. But I will tell you that we were moving along nicely in his program. And I had a hard time progressing his closed chain work because it's very important. I do a lot of all fours work with patients, especially with shoulders, because, and you put a yellow TheraBand around their forearm, it really sort of takes out the pec and it really fires the deltoid, which is a big strength hole in patients who have shoulder issues. But with him, I couldn't progress him. And remember, he had a history of a wrist fracture. His wrist extension was so limited on that side that I ended up, and I'm currently still treating him, I had to treat his wrist to get his shoulder, to progress his shoulder closed chain program, because I could not get that wrist extension. And that's fairly common, right? But know that there could be other drivers that will crop up when you start to progress your patient's program. And we've done a couple of podcasts on this as well, in terms of just tertiary drivers that come up, right? So with him, he was moving along nicely. I was working on his thoracic control, working on his deltoid, glenohumeral, getting him a little bit more control in his lateral deltoid, anterior deltoid. Then I couldn't progress him. I couldn't even progress him to a wall push-up. that aggravated him. And now I realize why, because he had no wrist extension in his wrist. So we ended up treating the wrist, and he's significantly better. So that's sort of the I guess the take home message for this guy. Same shoulder, same symptom as the other two, but once again, different history. And it's important that, I know we've hammered this home so much in our podcast, but so important to remember the patient's history. Second patient, the older gentleman with the I can't cross my arm across my body. A bit more straightforward, but he had been working with a trainer doing a lot of sort of overhead presses and cuff work again. Once again, not really helping him, because, if you think about what needs to move when you take your left arm across your body to put your left arm on your right shoulder, you need some scapular mobility, right? You need a little bit of, abduction, right? So he didn't have a lot of compression in the shoulder joint like my prior patient did, but he has really very poor scapthoracic mobility, a bit more straightforward. However, if you didn't assess that particular movement, you probably could have gleaned it, once again, as I said, from looking at his left sal. But he would benefit from some scapular, movement repatterning versus your cuff work. And he obviously wasn't getting better with that. So once again, it's about what's the movement that bothers them, what needs to happen, and what is not happening, or what is sort of not optimal. And you try to modify that or correct it, as I say, and see if it makes their symptoms better, or their movement better, or gives them a better experience, right? I always like to say better experience versus, is your pain better, or how are your symptoms? So I just facilitated some scapula upward rotation and abduction, and he was like, oh, that feels much better. So, and it looked better. So once again, think about the movement that you need to assess. Patient number 3, my woman in her 50s, left anterior shoulder pain, has a hard time lifting her arm up and putting it behind her back. Immediately, I assessed her sal first. She went literally from 0 to 20 degrees of shoulder flexion, and I felt a superior glide in her shoulder, and her neck, her muscles in her neck were like on fire. Yeah, she has neck issues on and off, but who doesn't, right? But she had significant hypertonicity in bilateral, both of her cervical extensors, levator, rectus capitis. All of the muscles in her neck were super hypertonic. And so the minute she lifted the arm, it was like the shoulder hiked, and her whole cervical spine shoulder complex, she went into this left side bend. Not optimal, okay? And certainly not a meaningful experience for her. Actually, it was quite painful. And very similar with her hand behind the back. That is a tough movement, as I said earlier, but, same thing. I saw the same, I don't like to use the word poor, but the same not useful movement strategy, hiking the shoulder, superior glide, and just a lot of compression superiorly, versus my prior patient, the first guy with the wrist issue. He was more medial compressed, she was more superior. So what I ended up doing was, because the neck was the first thing I saw that was gripping, I went in and once again, this is for a different podcast, but I ended up doing a little decompression up in her neck, and I had to repeat the task, and it was significantly better and that's just a straight shoulder flexion. That's a straight sal. It was much better. And when I had her do the hand behind the back, that's when her other areas of her shoulder complex began to sort of rear their ugly heads, as we say. So when I ended up decompressing her COC1, when she did her hand behind her back, it made it better, but it wasn't like the wow that I got with her sal. So she has a secondary driver in her shoulder joint, in her glenohumeral joint, that once again, more of a superior glide type of issue versus like an anterior or a medial compressed. So with patients who have shoulder issues, there's many areas, the shoulder's 3D, right? You need to assess everything in 3D, especially these ball and socket joints, right? So with her primary issue is her neck. So I treated mostly her neck. I'm still treating her. And secondarily, I'm giving her some shoulder repatterning, but you want to intervene in the area that's going to give you the most bang for your buck from the get-go early on. And with her, it is her neck, her COC1. ironically. It's not C6, C7. It's not like, mobilizing her C6, C7, releasing her levator scap. No, it's getting her doing a little bit of decompression or COC1, doing some dynamic release of some of her deeper cervical muscles. That actually got her sound much better, and her hand behind her back. Her hand behind her back needs some shoulder work, but it's much less than her neck. So with all of these patients, with the first guy, he obviously has a thorax and a shoulder issue. You're going to you're not just going to give him shoulder exercises. You're going to need to give him exercises that are going to really help him with his thoracic control. And with the second guy, with the anterior shoulder pain across the body, it's going to be mostly scapular repatterning. And with my last patient, the woman here, you're definitely going to give her work with her neck. And I did a lot there's a lot of release, honestly, with the ball first, but these patients will require different exercise progression. So same symptom, different drivers, and different exercise prescriptions. So I wanted you to hear this before you listen to the podcast, because I think it'll put it all into perspective. Anybody has any questions, feel free to reach out, and we hope you enjoy the special shoulder episode. Bye.
Hello, everybody, and welcome to Tough to Treat. I'm Susan Clinton, and I'm here with my co-host, Erica Melo.
Hey, Susan. How are you?
I'm good, Erica. How are you?
I am good. Good.
We were just chatting about the time that we're recording this podcast. It's, I think Erica was saying it's been 90 degrees many days in a row in New York City. The concrete jungle, eh?
Oh, my God. It's like 97, 95, like the real feel of 100. Like you can see, like when you walk up or down the streets, everyone's on the shady side of the street or no one's on the street at all.
Yeah, they're staying inside.
Yes.
And I don't blame them a bit.
I know.
We've been warm in Pennsylvania, but we're not on the eastern seaboard in Pittsburgh, so it's been not as warm as you all have been up there.
Yeah.
So we have a lot more humidity, I think, but it's hard to say.
Yeah.
It's the summer.
I know.
It's supposed to be warm.
It is. I know. But every year I keep saying it's more humid and more hot every year. It's crazy. But climate change.
Yep.
Are you ready?
Yeah, I am. We're going to talk about a client that came to me kind of mainly because his wife has been seeing me. And she's been pestering him for a couple of years that he should probably come in and let me take a look at him and see what's going on. And then I guess one day he just decided to make an appointment, which was great. I was kind of surprised when he popped up on my schedule, but I thought, wow, I wonder what, kind of precipitated this.
Mm-hmm.
So interesting. This is a male around the age of 44, very tall,
Mm-hmm.
probably like 6'5", 6'6". Very thin, so you kind of almost start thinking, wonder what's going on autoimmune-wise with this guy, it's Marfan's or something else,
Yeah.
Didn't really have like what I would consider gigantic hands or feet or anything, but very tall. And, he told me that he's had an 8 to 10 year history of intermittent left shoulder pain. And he has seen a myriad of people for this. He's been to many chiros and to many PTs and had the shoulder injected a number of times. He's, been popped and manipulated in his thoracic spine. He's had people do myofascial work on him in an effort to, according to him, to balance out and level up his shoulders because his left shoulder is always high, his right shoulder is always low. My question to him at that point is, are you right or left-handed? Mm-hmm. He's right-handed. Okay. So
where was the shoulder pain again?
He just kind of would touch all around, the top of his shoulder and kind of through the shoulder a little bit.
Got it.
He would always just reach that arm over and just kind of touch, that kind of upper trap area and into his shoulder itself. And I asked him, I said, if you had to specifically point to one spot, or is there spots on your shoulder that bother you, or is it just generally the whole thing? And he said, interestingly enough, the one spot that gets me all the time is underneath my shoulder blade. It's like, okay, left shoulder pain, underneath the shoulder blade. We'll talk about that in a minute.
Yep.
And, so he's worried about the asymmetry. He says, I see it all the time. I see my left shoulder all the time, raised up higher. I'm wondering if I'm crooked. Has this brought on something really bad in my back? And I said, do you have back pain? No, I never have back pain. He said occasionally, he said, occasionally I have some knee pain, but it's not a big deal. But no, it's just mostly this left shoulder thing. And I said, okay, any other things such as headaches or, do you have pain that ever goes down? Where does your pain do anything different?
Right.
Besides just sit right there. And he said, no, he never feels it anywhere else. It's always just kind of right there. We kind of moved into this persistent condition here, for quite some time. 8 to 10 years is a long time to be doing this. I said, what makes it worse? So he says, I notice it off and on when I have long hours at work. Does a lot of, he's on the computer a lot and on the phone a lot for his job. So he's just busy all the time, meetings, constantly on the go. So depending upon how long his hours are at work, that can bug him.
Yep.
He also says he's worse when he is loading his body. So he said, I used to have a HIIT app that I would turn on and it would say, your HIIT for the day is, 20 planks, 30 push-ups, 47 squats, 5 minutes to complete, whatever, how that high intensity interval training works. Yeah.
Got it.
So, and he said, I had to quit doing it because it kept aggravating my shoulder. And he said, and it was when I would do things where I had to put my hands on the floor and move my body over my hands that bothered me. And he says, and also carrying my child. He said, my child is 4, but he's very tall for a 4-year-old. And if you look at this guy, you could only imagine.
Yeah.
He must, and his wife is very tall. I mean, they're Amazons as far as their height goes. So
that's funny.
So carrying the child, he tends to bring the child over to the right arm a whole lot because that bothers him there. And through this whole thing, he just kept always like touching and massaging his upper trap. Just kind of like would tell me a story and reach over and touch it. I asked him, I said, what do you think is wrong? And he said, well, it's interesting because I'm very frustrated because I can't get this better. And I said, okay, but what do you think is wrong?
Yeah.
And he said, I don't know. He goes, I think maybe I probably have some sort of arthritis in my shoulder and I'm going to have surgery or something. I'm just never going to be able to use this arm, to push things around and push my body around and do the exercise I want to do and those types of things. So he said, so I've been, he goes, I carry a backpack and I hike. We go hiking a lot because they love to do that. And he says, I feel like I can get some strength training that way by, kind of putting some stuff in a backpack that makes it a bit heavier. Yeah. So he has to, haul it up and down the hills. And that doesn't seem to bother his shoulder. Just regular walking doesn't really bother his shoulder. If he had to sit in the car a long time, it's hard for him to tell because he says there's always that kind of level of bothersome or pain that goes on, but it doesn't flare
driving.
It. Yeah. But it doesn't really flare it like, oh, wow, I have to quit doing what I'm doing because that really is bothering it. So he's got this kind of low-level thing. And I think when we were talking, that bothers him more than when he had the flare. Like, he goes, when I do something, I know I did it and I can figure that out. He goes, this constant humming of it really bothers me. And,
Did he have any relief with anything like the shoulder injection or any? None of that worked. Okay.
Nothing.
Okay.
So I said, okay, let's take a look at everything. I know where I'm going, but I needed to start at the shoulder because he came to me and he wanted me to look at his shoulder. At this point, I don't know what you're thinking, but I've got all kinds of bells going off in my head about, has anybody looked at this guy's cervical spine?
Totally. I mean, that would be the first thing. Yeah.
I know they've looked at the thorax and they've maybe but they've only looked at the upper thorax. And so it's like, okay, we've got to take a look at what's happening up the chain, down the chain, and see where this is getting, what's going on here.
Yep.
So I got him standing. I got him moving a little bit. I had him do a deep squat because I just wanted to see what he was going to do with his body, that very long, tall body.
Mm-hmm.
And he kind of does the squats where he would like dip his thorax first
Mm-hmm.
to lead into the squat, and then eventually squat by bending his hips and his knees.
Mm-hmm.
But it would all start up top. So
Yeah.
that was kind of how he chose to move that very tall upper body over his base of support. I had him bring his feet apart. He was able to do it with less thoracic dipping and head dropping, which was, so he could change. I was just trying to see, where we were, what was happening with moving and stuff. And the fact that he was moving a lot up there first and not really as much down low, I kind of put it in the back of my head and said, I'll just pocket that for later.
Mm-hmm.
Because that's not something I'm going to really address today. He's not having pain with that movement. It's not making this pain worse.
Mm-hmm.
It's not really changing anything, but, he can certainly change his movement patterns a little bit to where he's not over moving the whole upper quarter
Yep.
and under moving the lower quarter, as Shirley Sarman would probably call that, the tail wagging the dog,
Yeah.
The upper part moving, more and further than it needs to for this particular, movement function. But
Yeah.
part of that could be that's how his brain is organized, how to handle this very tall upper body over this, very long lower body that is very thin,
Mhm.
naturally, genetically, just, thin, tall people.
Yep.
And did some other things. I had him twist, he barely turned his head with twisting around and, didn't use his eyes. Clinically, I see this all the time. I cued him, so I said, just turn around and look at me. He didn't do a lot of movement with his head, but he was kind of twisting all the way up and down. Where he needed to use his head more, he didn't use it, and where he didn't need to use it so much, he used it a lot. It was kind of interesting,
So when you had him twist, was it thorax or just the head you had him rotate?
I had him standing on his feet. I had him
he's standing.
Full body twist, just to kind of get an idea of, just up and down the chain. Where are you moving? Where are you not moving? So, and basically, he just wasn't going to really turn his head a whole lot. Just wasn't willing to do that.
Mhm.
So I didn't pester with it. I just, I said, do you have any problems with this? Oh, no, not really. Nothing more than usual. But I wasn't doing enough to like, I probably did it 15 times. Maybe it would have brought something on, but
Yep.
I didn't see any point in doing that right at that moment. So sat on the bed and did some twists there.
Mhm.
And that's when you could really start to pick out particularly in the lower thorax, he just was really not moving a lot. He would his shoulders would come across his body to do the movement,
Mhm.
but the trunk itself would not do the twisting.
Interesting.
Yeah, it was interesting. It was like, okay, so over moving the shoulders, not really moving the thorax. The movement should have come more from the thorax and less from the shoulders.
Right. The shoulder
Mhm.
girdle. It's interesting because I find that with a lot of these tall guys, like the ergonomics, like the seats are not meant for these tall guys
Mhm.
or tall anybody. It's just
Right.
they have to crouch and lean forward, and they get that typical forward head posture, and
Mhm.
because they're so tall they have to compensate, and especially if they're looking at computers, it's a lot of it's the upper C-spine and the neck, and then they develop these thoracic kyphosis and tightness, and it's really interesting. I mean, I think that if you're too short or too tall, it becomes sometimes a problem when you have to do a repetitive activity for a long period of time, I think, anyway.
Yeah, I like that because, he's trying to mold himself obviously into an average world.
Yeah.
And, he's never going to be an average height, and, everything is always going to be different.
Mhm.
We'll get to a little bit of what we talked about with his ergonomics in a few minutes, because it's interesting you brought that up, because it was certainly in the back of my head too. It's like, this bothers him at a long day at work, but he's got a lot of variance at work because he's in meetings. But
Mhm.
the one thing stays the same, the name of the game stays the same, is that it's always from a seated position.
Mm.
Whether he's, on the phone, whether he is on the computer, if he's at a meeting, he's generally in a seated position. I did get that out of him in the history, which I didn't say, but that, that's, when we talk about ergonomics, and we will in a little bit, that was, kind of a key piece.
Yeah.
Because he's trying to fold himself down into, like you say, chairs that he doesn't always get to have control of.
I know, it's so funny.
And his desk he does, but again, what can be changed to make that fit him, because people are going to fit themselves into their environment. They're generally not they generally don't move their environment to suit them to begin with.
Right.
So people tend to, and I'm not talking about that we have to get people into ergonomics to where they're locked in. Like I don't want this guy to be ramrod straight in a chair all day long either. I want him to have the variability to be able to move in and out of postures in a way that his environment will allow, so that he can have some variance, throughout his day and not kind of get all in.
Yeah.
And we'll talk about that in the eyes in a couple of minutes. So so I had him, I cued him again to turn his head and his eyes, and he was kind of getting better at that. And he goes, I just don't think about doing that. And it was like, well, it's okay. I said a lot of people don't, we'll get that rolling, because we want to, get you moving here. So we looked at the shoulder. We raised the shoulder in the air. We put it behind his head. We put it behind his back. You can only imagine there wasn't anything in his shoulder that I could elicit or do. None of the special tests, nothing. I mean, and I knew my confirmational bias going in was already that this isn't a shoulder problem, but I wanted to convince myself. So off to the races I went. I also did a neuroscreen, for people who are thinking, well, what else could it be? And he didn't have any signs or symptoms of radiculopathy. No. But I still did a neuroscreen anyway. Didn't hurt. Quick, light touch. Dermatomes, myotomes, relatively fine. You say, when we got up to doing the deltoids, out, he's like, well, a little bit there maybe, but really nothing that, stood out. So the neuroscreen was pretty clean. Yeah. No history of dropping things and, the hand not working or, having arm pain with any of his activities at all. It was always just kind of in the shoulder.
I think people who have that upper trap, they pointed their upper trap, they're always going to be leading with that, even if it's not their shoulder as the issue. They're just going to do upper trap lift. Oh, it's a little sore. And that people, leads people down the route. Oh, it's a shoulder. But you see a lot of that in neck patients too, and any other diagnosis. They just do a strategy. They lift their shoulders, and that's that. Because he's been doing it for years, probably 8 to 10 years. He had this thing, so he's compensated. So
and so we talked a lot about that when he was talking about the asymmetry. That was my chance to jump in and do a little bit of just kind of like, you're worried about this. Let's discuss this a little bit, because it's this is a fear thing for him. This is kind of driving. It's one of those scary things for him that could be driving a piece of his pain. And we talked about it. I said, it's interesting when you have something that you have a pain response to, your muscles have a response as well. And some of them tend to over-recruit. Others tend to under-recruit. And so you get kind of an imbalance, a discoordination around your shoulder, because you have some muscles that are really trying to run the show, all of it. And the other ones are kind of like, hey, peace out. If they're going to do all that work, I can't fight it. I'm just not going to do it. Yeah. And, so I got him kind of thinking a little bit like, oh, okay. And I said, let's keep going, and let's see if we can't figure out and maybe get, these muscles that are overworking to stop working so hard, and the ones who aren't working, let's invite them onto the playing field. But first, let's just kind of do, and then we went into the movement stuff and that kind of thing. So I just decided that, he was talking about this, and, and so I just put my hands, I was going to put my hands on his thorax and have him move his shoulder around and see if it made a difference. And I just said, no, I'm going for the head. I'm just going to go. So I got on his head, and I just did some compressions down into the system. Didn't really change anything. So it was like, and it wasn't acute and irritable. So I wasn't really expecting it to. I just wanted to see what would happen when I loaded,
so
from the top down. Yeah.
Like a head, you put the hands on top of the head and you compress, like a compression test.
Exactly. Loading from the top down.
Yeah.
And then I just put my hands right underneath the occiput on both sides and did a lift.
Interesting.
And I just sat there for a second. Well, more than a second. I was just talking to him, and I said, sometimes, we're tall, and, sometimes the positions, because the head and the neck and the shoulder all work together, because I think he was kind of wondering what I was doing. And I said, how does that feel? And he sat there for a few seconds, and he moved his shoulder around, and he kind of adjusted a little bit, and, shimmied it back and forth. And he said, I don't have the pain anymore.
Aw.
I was like, oh my,
Thank
it's like,
God.
yes, because it was like, wow, look at that, I'm magic. And it was like, okay. And he goes,
Yeah.
why is that? And I said, well, loading seems to bother you. This is a way to deload, or take the load off. And it's good,
Yep.
I said, some of this could just be, I said, maybe in the beginning, your shoulder, you had something happened. I'm not saying that this didn't ever start in your shoulder. I'm just saying that now your shoulder is moving fine. That where you're being hung up is somewhere up here in your neck.
Yep.
And by just doing this lift tended to make you feel better right away. So let's go with that.
Yep.
Because if we can do some things and get you into some positions to where you can unload your neck and feel better, that's going to be really important. I didn't tell you that it was one of those things that came in that said, I'm going on vacation, and so I want to feel better when I'm on vacation 1 week from now, right?
Right.
Don't you love how they do that?
Exactly.
I'm leaving in a week, so, and I'm really busy, but I took time off today to come in and do this. So it's like, okay, I've got, this time with him. Let's get it, the best things for his buck, as I said,
Sure.
I realize your goals are that you want to be able to load and do this kind of exercise, but first we have to get this to settle down.
Yep.
And that means changing some patterns and some things. However, we know that we can get you to feel better right away if we do some of these things. So I had him, and I do this in my courses as well. I laid him down and lined up his airway, like I do with the pillows and the stuff, and got him in a great position. And I said, how do you feel? He goes, I don't ever sleep on my back because it bothers me. This is the first time I've been able to lay on my back and feel really good.
So for the listeners, you put pillows under the knees, under the head. So
yeah, so I always, just because it feels good to have a pillow under the knees.
Yep.
This isn't going to be a position he's going to sleep in for 8 hours. He's a side sleeper, and we did move over to his side to get him sorted out so that he wouldn't have the pain in sleeping either. So I just look at how they are, and with him on the table, when he would lay down flat, his head would kind of crane backwards.
Yes.
And it was hard for him, and it didn't feel good. He was going into compression in his upper cervical spine and CT junction area. And, he wasn't able to do well that way. So all I did was put a pillow under his shoulders and his head, and then I kind of lifted the head up a little bit more with a folded towel and just got him in a position to where his neck was long. And his head was kind of lined up. And if you imagine the airway from like the back of the throat down into the chest, you can kind of almost see when you get him up out of that position that I took a kink out of the airway and just made it a little bit easier, more efficient for him to breathe, and his breathing got a little bit easier and he felt better.
I'm sorry, Susan.
That's okay. Go ahead.
No, it's funny because when I have if I've had a few patients recently who have had issues in their neck, and it's definitely their neck, and you lie them, no pillows, nothing, and they're completely in this upper cervical extension, really compressed. And I have them voice, and their voice changes so much when they're with this compression pattern. Then you unload them and put some pillows, their voice changes.
Yep.
The phonation changes, right?
Right.
I think that's fascinating.
Because the airway is open and they're able to access it a lot more efficiently. So there's not a strain in the airway anymore. That's why I use a lot of voice and breath with stuff I do.
Yeah, that's awesome.
That's really good.
Yep.
So I got him into that position. So here's a laying down position. Here's, my goal was, let me get this guy decompressed enough with several positions so that he can access this at different points during his day. So we got that. He wanted me to take a picture. I did. Here you go. Take it with you. We did a couple of things. I got him to do, like, in yoga, I think they call it ragdoll. But basically, I just had him bend over at the hips and, cross his arms and let them just relax, and his head come down and relax and get into a position where he could, like, invert, turn his head upside down.
Yep.
and that felt good. He
Yep.
liked that. So
Yeah. Almost like on your all fours too, dropping your
yeah,
head down on all
yeah.
fours. Yeah.
So, but I just actually not on all fours though, but I had him standing and do it.
Yeah. No,
Yeah.
no.
And
Yeah.
so we kind of just translated that into a child's pose position that
Mm-hmm.
suited him so that, he could get his neck longer.
Mm-hmm.
And all this was designed to get the neck longer.
Yep.
Get it out of, just decompress it a little bit. Get it out of all that compression that it's been sitting in for all of this time. And remember, this is a very tall guy.
Mm.
So he's never had permission really to be as long and tall as he
Yeah.
is. Like I basically was trying to give his neurological system permission to be tall.
To be taller, yeah.
Yeah. Don't be slumpy. You're a tall, great looking guy. Be that.
Mm-hmm.
So we did that. We did the lean over. We did the child's pose. We did the laying down piece, which was huge for him because he struggles with laying down and finding a comfortable position so he can lay down and get things to settle down.
Yeah.
And I had him turn on his side and I said, "Show me how you sleep." And we just kind of played around with some stuff to where he could kind of get his head and neck in a good position, and it felt better. So, which was, great that we had this opportunity, that we found something that took away some of his symptoms, because he, first of all, they buy right in when that happens, right?
Totally.
But the second one is they're willing to start looking for those positions because their brain starts understanding, if you do that, then I don't have to do this.
Right.
So, and we talked a little bit about, his work and what he could do there, because like he said, he goes, I'm not going to stand up in a meeting. I'm not going to do that.
Yeah.
And I understand, there's certain cultures and protocols around office stuff, and you have to respect the person and their environment that they are in, to do the things that they need to do for their occupation.
Mm-hmm.
I said, okay, that's fair. I said, do you have a computer when you're in the meetings? And he said, yes, usually I do. And I said, show me a typical setup. I had put the high-low table over there. I said, here's a chair.
Yep.
Show me what it looks like for you in, some of the meetings that you go into. And basically he would sit, and he would put the laptop out in front of him. We kind of made a table height that was like a normal conference table height.
Mm-hmm.
And he put the laptop out in front of him, and he actually pushed it away from him so that his hands could get onto the keyboard really well. So then you would see the head come down and the eyes come into the computer.
Yeah.
And so he had 44. This guy's 44.
Wow.
I said, when was the last time you had an eye exam? He just kind of looked at me, and he goes, I don't need reading glasses yet. I said, well, maybe you don't need reading glasses yet, but perhaps maybe what you could do is raise the font. To a little bit of a higher font.
Mm-hmm.
And I said, the reason is because sometimes when we have to peer at something for a very long time, we're going to adjust our head into a position that's going to allow that to occur.
Yeah.
And, when you're working that hard on those little numbers and putting them into spreadsheets and stuff like that, it's harder for you because you have to peer more, and the more you peer, the more it's going to pull your head forward. Yep. And it's not that I don't care about that I worry about a forward head position. I worry about it being there all the time. Mm-hmm. And I said, and that drives your symptoms.
Yep.
So one of the things you can do, because you're not going, you have to do what you have to do, is I said, and you want to slide that computer out, that's fine with me. But I said, raise the font up so you don't have to peer at it so hard.
Yeah, it's a great idea. I find sometimes, even with myself, because I cannot wear progressives, so I am farsighted. And so if I'm reading and I have the TV on, I have to literally drop my glasses down below and then peer over the top of my glasses, and I can feel the compression in my upper C spine when I do that. So eyes are really important with this.
Yes, I see this a lot also with people who do wear progressive glasses, because they still look underneath their glasses.
Yeah.
So they still raise their head up to look down through that part of the progressive lens that allows them to read up close. So I usually, if he raises the font, he's going to be fine for a while.
Yeah, it's a great idea.
Like even with the professor, my husband, Steve has a pair of computer glasses. That sit by his computer, so that he doesn't do that, because he wears those lovely progressive things, and he really knocks his head back to peer down into that. And when he, he's been it's much easier for him to do. He's doing a lot more online computer work right now with his classes. And so he had to kind of restructure and change how he's working around a computer rather than on paper so much.
It's very interesting. And I think
so those glasses have really helped, kind of just
yes.
help him feel a little bit less compressed and
Yeah.
less stuff. So anyway, so that was the suggestion I made to him. I said, play around with the font and play around with getting up and moving a lot. And he said, I think I'm going to order a high-low desk. And I said, that's great. I said, just be sure that, once it comes in, you may have to put it up on something so that when you raise it up, it's going to be tall enough for you.
Yeah.
Don't accept that, oh, it's only this tall, so now I have to drop down, that whole dipping of the thorax again.
Yep.
So I said, you need to kind of think about that, and it's okay. You may have to put something underneath it so that it actually starts off at a little bit of a higher level to raise up to a tall level so that you have that. And I said, and don't try to stay in a new position for a long period of time. The cool thing about the desk that you're wanting to get is that it goes up and down. So let it go up and down with you. Don't stay in something to fatigue. It was the biggest thing. That was kind of the take home for him. And then the final thing that I did, and I told him he could try it, I got some TheraBand and I got him to lay down on the floor and with his head right underneath the doorknob.
Lay on his supine.
On his back, and we hooked the TheraBand around the door and then slipped it up underneath his head to kind of do it like a traction.
Oh, so say again. So where's his head? By the TheraBand?
His head is in the so the TheraBand comes around the back of his head. So we'd have a loop of TheraBand that goes from the doorknob down to around the back of his head.
Got it. Okay.
So he's suspended in the TheraBand.
Oh, that's cool.
So I was trying to think of a way to do some manual traction or some sort of traction for him.
Yeah.
Not traction, but just how to get him, like something that he can do and just like, because I had like that first visit, that was it. It was like we had to come up with all these things,
So you wrap the TheraBand, like what color TheraBand? A heavy one?
I don't know.
Anyone? Okay.
It wasn't a heavy one, like a green or something. Yeah.
So you put it around the doorknob?
So I tied it into a big loop.
Okay, got it.
And then I looped it on the doorknob.
Yep.
And then the bottom loop, the bottom part of the loop went under his head.
Got it. Okay.
And then I had him, and then what he could do was he could like move his body away from the door so he could get a little bit more, he could play around with the angle of pull to where it would actually feel, like find the spot where the pain goes away. So he can move himself around, he can make get a little bit more traction or, have a little bit more stiffness in the TheraBand by moving away from the door.
I like that.
It lengthened his neck a little bit.
Yeah, because you see some of those contraptions that they sell online.
Oh my goodness!
Just ridiculous. I mean, it's like it looks like the person's going to be, they're hanging themselves with a
right.
Anyway,
so I sent him home with that, and it wasn't. I didn't have the highest hopes he was going to try that because it was a little bit of a. It took a little bit of thought and work and, but the other things, and, I wrote all this stuff down and sent it to him by email. So he had like the thing and the pictures. We took pictures of all the movements, that were going to be helpful for him, gave him the hints about hearing and the font size, and a couple of productivity links that if you take breaks every so often, you actually increase your productivity. So totally. I kind of sent those out and got him going. And he did go on vacation. And I have heard back from him. He said that some things were much better. It was just a quick email. I'll be in touch to reschedule. So, I don't know what things are better, what things aren't, but he definitely is going to be coming back in. So, it'd be interesting to get your take on kind of where you would go with him next.
Oh, sure. Yeah, I mean, it's interesting because I actually have a patient right now with similar complaints, ironically. Literally almost the same age. He's not that tall, but he does wear glasses. And the ergonomics, I think, I'll just start there, I think are really, really important, especially with someone that tall. I have patients just send me photos, and I think those are really important. And I have to say, I think that's half the issue in a lot of these people, because they're constantly sitting. And with somebody like him, unless he gets a bigger chair or really makes major changes to his workspace, he's going to have to, a sit to stand desk may be helpful for him. I like the fact of, I definitely would have gone to the neck as well, for sure. Especially when I see people who sort of put their hand on the rubber trap, I have a bias with that because I have neck issues myself. I'm like thinking upper C-spine. I just do. It's my bias. So you try to disconfirm, or whatever the word is, that bias, or negate that bias, right? So I like the forward. The forward bend, I would, I like the down dog. I would do, I would have him on all fours as well, and have him just let the head drop a little bit, and just maybe just do some lower trunk, upper like C-spine rotation. Like sometimes I have people get on all fours. They can do a little chin tuck and then do some rotation to the side, or I'll just have them just do forward bend and drop their head. Sometimes I have people lie on their side and have them do these thoracic openers. So they lie on their side, they're in the fetal position, and they're just doing, I think they're called book covers, and you have open the book and you have the head follow on both sides. I would probably do something like that. I like the fact that unloading the occiput really helped. I am just wondering if there's any, so he had no trauma or anything in his past, no head hits. Concussion, right?
Nope.
Okay. Yeah. So I think
it's cleared for any kind of study, because I looked for that for sure. Any kind of motor vehicle accidents, any kind of falls, anything, any head bumps or stuff like that. And he's a guy. He says, I like to exercise, but I'm not a team sport player. Never have been. And so he just never has been. Exposed to that kind of stuff. So no compression at all, which is
that's good.
Which is good, and like I said, he's such a tall guy, genetically, I kind of made me think and pause just a little bit about, is this somebody who may have a autoimmune marker for ankylosing spondylitis? I mean, he's got, it certainly doesn't have what appears to be a bamboo spine at this point. He doesn't have the kind of pain that goes on with that. He just has this shoulder kind of thing. But it was, something that when he comes back in, I'm definitely going to do a circumferential measurement of his lower thorax, with a big inspiration, and see if he's got the movement in there. If he doesn't, we're going to see what we can do to get that thorax moving better. Underneath it all as well. I mean, a lot of people have picked on the thorax in certain places, but I don't think anybody's really spent a lot of time just restoring rotation into the axial spine. Right. And I'd like to see him, like what you were talking about, the book openers and the things like that. I'd like to see him have some good functional reasons to really start rotating and moving that thoracic spine a lot more, and his head and his eyes a lot more. And as a break, even to maybe do some eye exercises and things like that, so that his eyes can get out of that locked in peered forward position that tends to kind of over time drive his symptoms up a bit in his cervical, from into his shoulder. I also think that with the ergonomics and things like that, I mean, I think those are really important. And I'm just wondering if I know people, they talk about deep neck flexor activity versus posterior extensor, like neck muscles. Is it a deficit in the posterior chain of the neck or the anterior chain? I don't tend to, I hate to say this, I tend not to do a lot of deep neck flexor work. I don't. And I've not found that to be the deficit in some of the patients that tend to sit a lot at the computer. A lot of it's because they're holding their head down, they're at their smartphones or on their tablets, and they have more of a posterior cervical extensor deficit. And in my experience, a lot of those people have a hard time doing like push activities, I think. So it would be interesting to see if you get him like prone on a ball and just, have him just do a little chin tuck and see if he can just hold his head in an elongated fashion and move his arms, like do some just scap stuff, just to see what his strategy is there as well. Right.
You
Yeah.
know?
I don't buy the whole longus coli thing either.
No.
But I do buy into the idea that the especially the suboccipital muscles, where 50% of the body's proprioceptors lie,
Yep.
are, don't know how to do eccentric work.
Yes.
And so restoring eccentric work to that area is super important,
Yes.
as well as elongation and being able
Yes.
to actively elongate, because that's the rotatories muscles, which is the multifidus of the cervical spine.
Mm-hmm.
And those muscles, when activated, can actually lengthen the spine. So
Yeah.
it's what we're after. And so in all fours, like you were talking about, I'm actually put my hands on both sides of his head and just take him into a lengthening position and get him to learn to hold that.
Hold that. Exactly.
And then teach him how to do that in sitting, so that when he sits up, he can come out of compression and maybe grow tall, rather than coming out of the sitting position and going into a craning of his neck position or something that's continuing to make his symptoms fire off. So heading into all those directions is where.
Yeah, that's great.
Mm-hmm.
Just no one's made him aware of that, and the fact that he couldn't hold any adjustments, or, I mean, you have to love it when someone's shoulder gets injected and they don't get better, and people still go for the shoulder. It's just mind-boggling to me, right? It's obviously not a shoulder, unless the injection was in the wrong spot, which whatever. But I think that people can't hold adjustments because it's not that the thoracic spine's stiff. It's their movement strategy.
Right.
They walk out of the office and they look down at their smartphone and bam, it's over.
Right. And so that, and his movement strategy is such that, remember, I told you that when I asked him to squat, the way that he organized the movement was to drop his head and his thorax first.
Yeah.
Rather than, fold at the hips and the knees first, so he chose to bend over before coming down. And that's just, again, it may have been a strategy developed around his height, but
yes,
I'd like to see him have some variance in that, to have some other choices to move without having to be the head and the neck, be the prime mover for the entire system, which is what I'm seeing with him.
Yeah.
Except for rotation. That's the one time he doesn't use his head and neck first.
Yeah, interesting.
But all the sagittal plane and frontal plane movements, it's driven by him moving his head first, and nothing from underneath. So it'll be kind of, if we can get him in, to get some of those fun things going, that will be fun to do too. But he follows pretty well, and giving him things to work on seems to do well for him. So it'll be interesting to see how he changes, and if his symptoms begin to really change and stay changed.
Even just getting him into some yoga postures and just trying to, like, triangle and opening him, opening up that way. But the key is to just unloading it. And I love the down dog, and all the child's pose is great ideas. That's where I would start actually as well. So
sounds good.
Cool.
Yep.
Love it.
All right.
Love it. Thank you, everybody. And thank you, Susan. Another podcast.
Another hour of learning.
I know, I love it.
And sharing. Thank you, Erica, for your insight.
Oh, thank you, Susan. And everybody, thank you all for listening. And we are so grateful that you listen to the podcast, and we would love it if you could leave us a review on iTunes. We would really appreciate it, and we would appreciate any feedback that you have for us. And you can reach us. Actually, we have our website coming, and it's called toughtotreat.com, and it's still a work in progress, but it's definitely a clickable link, but just, bear with us. So we're just doing some copy on it now, but it's there, and you can reach us there as well.
Mm-hmm.
Bye.
Bye.